Good afternoon. My name is Lisa Brown. I am the Professional Development Specialist for Simulation at Cleveland Clinic Martin Health System located in Stuart, Florida. This fall, I had the opportunity to collaborate with two of my colleagues, Rachel Iglesias and Delphene Lewis-Linton, who are both nursing professional development specialists on our staff development team. We collaborated on a quality improvement poster presentation that we prepared for Healthcare Simulation Week on the topic of identification of latent risk threats using simulation. A little background on the subject. As many of us know, healthcare sim is a widely used educational modality with many uses in healthcare education. When SIM is used for quality improvement initiatives, it is often conducted in the actual patient care environment, which we know as in situ simulation, as opposed to running cases in the SIM center. In situ SIM provides a safe opportunity for the entire team to interact in a clinical environment, testing and utilizing available systems, equipment, and processes during simulated patient care. Testing these systems within this in situ simulation also allows teams to identify potential latent risk threats, or LRTs, before patient safety is compromised. LRTs may lie dormant within the system for many years before they combine with active failures and triggers to create an accident opportunity. LRT identification focuses on analyzing systems versus individual care provider competence. Even in cases where individuals did not have prior knowledge or the skills, the focus of the inquiry becomes more system-based. Why did the caregiver not have the knowledge or the skills? With this framework, this provides an exploration of potential ideologies instead of placing blame on specific individuals. The Institute of Medicine, in their 1999 report, "To Err is Human, Building a Safer System," estimated at that time 40 to 80,000 Americans die each year because of medical errors. If we fast forward 2 decades later to current state, more recent publications suggest that the number has increased to approximately 200 to 400,000 individual deaths that are likely attributed to medical error annually. Our methods. For this project, we did a retrospective analysis of previously collected quality improvement data. We collected latent risk threats during simulation planning, or in situ rounding, and skills and other educational processes. The LRT data was collected from our nursing professional development specialist team during these educational processes from the time of January 2023 to September 5th, 2023. After identifying the latent risk threats, we documented the specifics of the communications that were made to leaders and stakeholders, along with specific mitigation strategies. In order to classify the LRTs, we used a known framework developed by Wheeler et al. That differentiates LRTs into medication, equipment, or system-based issues. We further classified the system-based issues into policy process, communication, and training and education subclassifications. Our categorization was independently performed by 3 raters. Our results: a total of 43 LRTs, including 41 unique LRTs, were identified. 3 duplicates were noted related to missing Zoll equipment. When we look at the breakdown of all of the LRTs, we found 16 were related to equipment, 1 medication, 18 were systems, education and training, 7 were system policy process, and 1 was system communication. Of the total LRTs, 67% were discovered by in situ skill or simulation modalities. 18.6% of the LRTs were identified by in situ rounding education. And lastly, 13.9% were identified by simulations or skill-based training within the SIM Center. By running in situ SIMs and skill-based education in the hospital units, we were able to more accurately identify the most LRTs as well as develop proactive solutions by involving frontline caregivers and their leaders prior to these issues becoming compromising patient safety. We think in situ SIM programming is a feasible and effective mechanism for discovering LRTs and can be used by interprofessional departments to minimize threats to patient safety. In conclusion, we find that our project adds to the growing body of evidence that emphasizes the importance of intentionally involving frontline staff and clinicians in patient safety and QI paradigms of high reliability. In situ SIM and debriefing provides a unique opportunity to include frontline staff who value the opportunity to be aware of LRTs and authentically connect with their leadership and our team on solutions for mitigation. Furthermore, we discovered that our own internal process for LRT identification, tracking, and mitigation had multiple opportunities for improvement. Going forward, we have created a standard monthly tracking process with a communication template, timelines to leaders and stakeholders, as well as quarterly follow-ups and communications. All of these are aimed at long-term mitigation of LRTs with the emphasis on collaborative efforts to create a more high reliable organization. I've included some references below that we used for this poster presentation, and our contact information is within our bios. Thank you very much for listening to this presentation.